Live to Give ISOD Live to Give ISOD International Scientific Organization of Dentistry. كنا معكم ول5 أعوام سابقة ساعدنا فيها آلاف الطلبة والخريجين من كلية طب الفم والأسنان في كل مكان عن طريق التجميعات العلمية الضخمة والمتنوعة من جميع الجامعات المصرية، وعن طريق الكورسات المختلفة والموجودة في البوت الخاص بنا على التليجرام. جاوبنا على آلاف الأسئلة المطروحة وساعدنا أكثر من 40,000 طالب ومتخرج من خلال المجموعة الخاصة بنا على التليجرام، وقدمنا محتوى علمي ضخم ومتميز لأساتذة طب الفم والأسنان في مصر والعالم، وتم ذلك في مؤتمراتنا العلمية وعلى مدار 4 أعوام على الصفحة الخاصة بنا على الفيسبوك، والتي وصلت لأكثر من 18 دولة. وها نحن نعود إليكم من جديد في النسخة الخامسة من مؤتمرنا Empower Your Knowledge A Free Online Dental Conference لكل أطباء الأسنان وطلبة الجامعات في مصر والعالم. نقدم لكم أكثر من 30 محاضرة متميزة في جميع مجالات طب الفم والأسنان. Case Discussion Live Demo and Clinical Cases. بدايتنا في 25 من أغسطس إلى 1 من سبتمبر، وستكون هناك هدايا وسحوبات يومية. Powered by ISOD Live to Give خير الناس أنفعهم للناس.
معنا ومعكم الدكتور إسلام قاسم PDS MSc FDS RCS Senior Consultant Maxillofacial Surgeon Head of Maxillofacial Surgery Department عالمين Hospital، والدكتور باسم عماد Oral and Maxillofacial Surgeon PDS MDS Cairo University and Hong Kong University MOMS FDS Royal College of Physicians and Surgeons Glasgow MOS FDS Royal College of Surgeons Edinburgh FCG Dent College of General Dentistry. في محاضرة شيقة تحت عنوان Minimally invasive implant.
مساء الخير يا جماعة. It's a pleasure to be with you today. I think we're going to start our webinar now. Our topic today is the minimally invasive method of implantology. And we would like to classify the invasiveness. It's minimally invasive is a part that we will do the minimum invasion to the tissues during our implantation. There is non-invasive technique which is not related to dentistry, because even diagnosis is potentially invasive. When you are doing probing, you can have bleeding from the gingiva. And the invasive is the traditional methods of implantation using the open flap technique. Why minimally invasive implantation? This is what people think about us as dentists. That would be your first patient. You do enough invasion, and this is a very famous song that is called I'm a Dentist. So when you do an invasive procedure to your first patient, that would be your second patient in panic. And when you go for patients ever after, you will not find the patients, or you'll find your patients running away. You would need to be a magician, or you would need a miracle to put the patient back on the chair. And that how the patient would be looking like. Blood battles have been fought, and unfortunately, they are still being conducted in implantology. And for example, those are implantation procedures that have been done by me about 20 years ago. That's just to gain a horizontal dimension, screws, bone grafts, iliac crust graft, retromotor graft, mental graft, and that what you would find from the patient. It is generally agreed that elective surgery should not impair the patient quality of life, and implantations and elective surgery. And it should reduce the surgical trauma as much as possible, and should confine the patient morbidity to the minimum. This is how you need to work, because you have to think about your patient. The patient comes like this to your clinic. He wants to go out of your clinic like this without sitting on the dental chair, if possible. So, this is what the patient is thinking of. And the patient needs the minimum of intervention from you. So, this is what we have to think. Change. Change is a law of life. If you look only to the past and the present, certainly you will miss the future. So, what is considered invasive in dental implantation? Extra expenses to the patient for no clear reason, unnecessary implantation dimension, like putting an implant for an upper lateral incisor 16. This is not going with nature. You should think about the root length and the root crown ratio, and that would tell you the exact dimension for the implant. The extensive lab design or procedures could be avoided medication, unnecessary x rays, traumatic instrumentation, or prolonged treatment time. In minimally invasive, we have like thousands of titles talking about minimally invasive implantation, but we until now we don't have a definite criteria for the minimal invasiveness during implantation, and unfortunately there is no concept that is well established yet, and this is what we are trying to do. And in my opinion, implantation is much easier than endodontic treatment. As you can see, there are much more complicated procedure and time-consuming procedure doing in doing endodontic treatment than doing implantation. And implantation is nothing out of the ordinary. It is the most documented field in dentistry, and it has achieved 93% of success during the past 20 years. There is no need to go out of the norm or change everyday practice. Endodontic treatment is also invasive, and we don't do that while we don't dress like that, we don't do this. Of course, it is pretty much important to have sterilized conditions in the surgery room, but not excessive, or when the patient comes and finds something like that, I'm going to do something out of the ordinary, and the patient would be panicking, like the video that we have seen before. Also, there could be avoided medications to prevent the complication occurring in surgeries or extensive surgeries. We usually administrate anti-inflammatory drugs, and this is scientifically proven that anti-inflammatory drugs impair osseointegration process. So we might not need any anti-inflammatory drugs, non-steroidal, of course, is the one that impairs. I prefer using the steroidal anti-inflammatory drugs just for 3 days after the surgery. With minimally invasive implantation, you don't need, might not even need an analgesic after the surgery. Also, the x-rays in the stage before or during the implant placement, yes, it is pretty much indicated to get x-rays, but for the second stage, if there is no second stage surgery, you might not need any x-rays. And for the follow-up, as long as the implant is in place, there is no looseness, there is no indication to make an x-ray. It is not indicated to have an x-ray just for follow-up. So, MIMI, or the minimally invasive technique, it's a technique-sensitive procedure with a steep learning curve. You will have to practice more to get more tactile sensation and sensibility, and it necessitates particular instrumentation. And that would drive me to talk about or to present this. And this is how we do it. It's not just that we are going flapless without making any kind of flap, but the instrumentation we are using here is pretty much important. Just placing the implant, and that would lead us to talk about the special implant that is adapting the minimally invasive technique, which is Champion's implant. We will talk about it. You place the transfer coping, you take the impression, and the patient comes. After you send everything to the lab for preparation, the patient comes within 8 weeks to 12 weeks. You remove the shuttle, which acts as a gingival former. We will talk about everything in particular. You remove this shuttle that you used to put the transfer coping, and this is the shuttle remover. This is how it works. And then you put the abutment, screw it in. You already took the impression, so you will put the final restoration. This is how simple it is. It is a simple procedure with a specially designed implant for the minimally invasive that put in place every part that you need with a single surgery, even it's not considered a surgery because there is no flap. That is the idea of Future Dental Academy in Flonheim, Germany, that I am a scientific advisor for the Future Dental Academy there, and we are implicating everything, and we are trying to reach the final concept for minimally invasive implantation method. This is our classification for minimally invasive method of implantation. Thus, MIMI 0 is immediate implantation, where we extract the teeth and immediate placement of the implant. MIMI 1 is the late implantation after extraction, where there is enough bone horizontally and vertically. MIMI 2 is the horizontal distraction, when we increase the ridge width by cortical splitting. Vertical distraction, when there is no enough ridge height. Horizontal and vertical distraction, the indirect sinus lift or indirect or internal direct sinus lifting. So we will start talking about the osteointegration and the biointegration of the implant, where the shuttle is the key step for this implant. Of course, it has a platform switching. The micro gap is 0 to zero point 0.6, and the micro V-shaped threads, 9.5 double cone with internal hex. It's titanium grade 4. The shuttle is the one that we are talking about now, and this is the tool or the instrument that allows us for applying the minimally invasive implantation. And it has the main rule there. It's an insertion tool. The implant comes like this on a plastic holder. The surgical site closure, it closes the surgical site and it acts as a gingival former, and it has an attachment for the small pig when you are trying to measure the implant stability using the steel measuring device. And it's an impression tool either by transfer coping or scan body. It fits into the shuttle. The instrument has extra uh, uh, condensers other than the usual drills, which is triangular in shape, and these are the sizes of the drilling. And we will have to talk about the condensers. These condensers, it could be used as a drilling tool, and it could be also used for condensation of the bone. Of course, we all know that bone densities are D1, D2, D3, and D4, where D4 is the least dense bone. So we use the condensers to do what we called metamorphosis or bone metamorphosis. When we condense the bone, we change the D4 into D3 or D3 into D2, but we don't use the condensers with D2 or D1, because D1, when we do extra condensation, there will be an extra pressure on the bone and there will be bone resorption and we might lose the implant. We all have to know the placement of the implant, ideally, according to scientific proven evidence, that it should not exceed 40 newtons. It's ideal between 30 and 40. It could be between 20 and 30, but we would need it to be between 30 and 40 Newton as initial stability. More than 40 Newton, it has been proven that it causes pressure on the bone, and that would lead to bone resorption. It might lead to losing the implant or delayed healing due to the bone resorption that was initiated by the extra pressure on the bone. So those condensers are being used to do the condensation, and it has the same morphology as the implant, that you can place the implant and gain more initial stability without doing pressure on the bone. We have to know that the vascularization, this is my pride and joy. It's my master degree, and it was done by Hong Kong University and Cairo University in a joint venture. And the vascular endothelial growth factor augments the healing of demineralized bone matrix. So we have to know that the vascularity is the key step for healing. Without proper vascularization to any surgical site, not just the implant site, there will be delayed or non-healing. So the vascularization is the key step for healing. And that's scientifically proven, and it was in 2006, and it had a Harold Ayres Prize for best published article from the International Journal of Surgery. As we were saying, the response of bone to pressure is resorption and bone deposition on the other side. And we were talking about the condensation. We don't need an extra condensation for the bone because we want to place the implant between 30 and 40 Newton to avoid any pressure on the bone, to avoid any kind of resorption. So the angiogenesis is the key step of healing, as we said before. When we do a flap, that what we see, and we will have revascularization again, and it will take much more time. Without raising the flap, we will have intact vascularization, so the healing time would be much reduced with us. And that's why we recommend that we can do the prosthesis within 8 to 3 months after implant. And that's because the difference that we had between raising the flap, interrupting the blood supply, and without raising any flap or interrupting the blood supply. And it's not just in simple implantation. As we can see, we will discuss in the cases that we are going to present right now, the other techniques that we do, cortical splitting even without a flap. Uh, Flapless does not mean that we are working blindly when we are inserting our implant, because we have ridge mapping, we have low speed, and we have sensibility and snip, which is cortically navigated implant placement, and the prosthetic guide. That would be how you work, where you know where you are going, and of course, by doing the necessary x rays before, you will, and ridge mapping and using low speed, you will not have a problem with inserting your implant. The cortically navigated implant procedure is that we go through the lingual cortical plate, we sense the buccal cortical plate, then we change the direction, we go, and then we place our implant. And this is a video explaining how it works, and the speed while we are working will let us have the sensibility of the cortical plates, and we place simply we place our implant. That's another video explaining with the live surgery. Notice the lingual approach and how it coincides with the graphics. And the sensibility, we're using the probe to make sure that we have the cortical plates. Triangular drills are, instead, of course, of the pilot drill, has proven that it is less traumatic. Placing the implant into the bone. Here, the implant by itself, because it was not a dense bone, it was D4, so the implant itself would act as a condenser. We did not use the other condensers, as we don't need to, or the other drills with the sizes. We did the condensation with the implant itself. And this is the guide, adjustable to the ridge side, to the ridge size. It opens from the middle part. As we can see, the latch in the middle part, it can be expanded or closed according to the ridge side, and it tells you where you can place the implants as anatomically as it should be while you are replacing the canines here and the first premolar. Here also, it can tell you exactly where you place the implants, because we have to go with nature, not against the nature where the teeth used to be. We need to place the implants as it should be placed. That's another surgery. And it's for a D4. And I'm using the condensers, just using the hand pressure because it's D4 and sensibility cortical navigated implantation procedure is also applied here. Because we were so close to the sinus and we did this is the indirect sinus lifting, as we will see in the X-ray. And as you can see, still I'm using the hand pressure. And this is the proof for bone condensation with the hand pressure is not applicable with the 3.3 condenser. So what we did here is the condensation is bone metamorphosis. We changed the bone from D4 into D3 or maybe D2 as well. As you can see, when we go further uh, with the condensers, the more resistant it would be, and that's a proof of the bone condensation. We went with the condenser to the 3.8, and so we are using the implant uh, 4 in diameter. That the implant would do the final condensation for uh, the bone. And here is how you can see the implant coming. It's mounted on this plastic holder, and that's how you insert it. And this plastic holder, when it reaches 20 Newton, it separates automatically. And this is another guidance for you. When you are placing the implant, you know exactly how much pressure are you applying to the bone. The shuttle is a placement tool, and here we will see that it breaks with the ratchet, gauge ratchet. It breaks. I'm adjusting it on 40 Newton, but I would not exert much pressure on bone to avoid any bone resorption. Okay. And that's how the implant would be on the mouth. You would have the shuttle appearing above the gingiva by zero point 0.5 to 1 millimeter. It should be not more than this to avoid any lateral uh, pressure on the bone. And here we can see that we have went into the sinus, and that's why we were doing the sensibility and the navigation when we were doing the drilling. It's about 1 millimeter inside the sinus, should be subcrystal. So that's how simple the indirect sinus lifting is. Of course, Dr. Islam will show us, if possible, the traditional techniques that used to be done before, and how we were doing the sinus lifting and bone grafting and iliac crest and the other procedure that is considered for me as history right now. Simplicity is enchanting. This is another case, and this is how you will do the final restoration. That's the shuttle, and you put the transfer coping or the scan body. You take the scan. Of course, here we are using the Medit scanner i600. You remove the screw, then you remove the shuttle. Then, because of the scanning previously, you just put your restoration in place and screw it back in. This is a screw retained a button, and we're screwing it back in place. So the first time you remove the shuttle is the time that you are putting your final restoration. That prevent the excessive manipulation to the implant, intern, internal part of the implant, and putting extra stress on the implant or on the extra or in the internal hex. There is no second surgery. You just screw the abutment in. So I think this explains why I'm talking about specific implant. Uh, that's because this implant is adapting the minimally invasive, and it's going with the development all the time to reach a specific criteria for the implantation with the minimally invasive techniques. That's another surgery that we are going to see right now. It's Mimi Zero, the immediate implantation. The patient comes with fractured upper left premolar, first premolar. After proper anesthesia. And as we said before, the instrumentation is pretty much important. These are the laxators. I prefer using the laxators than using the elevators because the force would be much more controlled. We were lucky it was one route, but of course, if it's two route, you would have to prepare the implant site to centralize your implant. Again, we are using the condensers. It was only one condenser, of course, because we need to go apically, about 2 millimeter to get initial stability between 30 and 40 Newton. Here again, we can find that the plastic holder of the implant with the shuttle separates at 20. This is the final. Again, we will also see the minimally invasive implantation O, which is the immediate implantation. As you have seen, those two, the central and lateral incisor in the right side was totally loose. One of them is endodontically treated and the other is not. And as we said before, we need to go epically, at least 1 to 2 millimeter to get good initial stability from the apical part, especially in the immediate implantation. Sequential drilling here is important, and you would know immediately that that case have a high bone density was a male, early 40s, and that's why we use the drills first to avoid any pressure on the bone. again the placement of the implant, and on the other side with sequential drilling. It was near to D1, that's why we needed to use the sequential drilling to avoid any pressure. Again, avoiding any pressure on the bone, because D1, when you place the implant with pressure, you would lose the implant immediately. So you have to do a relief in D1 without affecting the initial stability. You have to adjust it at 40. That's why we say that it is very important to adjust your initial stability between 30 and 40 Newton. And a lot of us would think that more initial stability is better, but it is not. Here's the X-ray. Here is another innovation. It's using the tooth. It's called smart dentin grinder. It does the grinding to the teeth, to the extracted tooth, where you get your bone graft material without doing any morbidity to another surgical site. Using the tooth that was extracted. Of course, it is not the one that had the endodontic treatment and the crown was removed before grinding. This is called blood stop. It's like a gauze. When subjected to water, it turns into gelatinous. It stays in the surgical site and closes completely the surgical site for about 5 days. I'm trying to give you the most recent advances that we are adapting to use in our minimally invasive implantation method. And of course, the pre-prepared temporary. With no pressure over the implant, and the patient goes out with his teeth. This is the smart dentin grinder, and it has a lot of researches that has been done on it. We will put it on the description. Or using the alloplastic graft also. Where in this case, we will extract the tooth and we will use an alloplastic material, which means synthetic material that acts as a bone graft. This is usually how the X-rays looks like with the alloplastic materials. And this is MIMI 1, which is late implantation. We prefer after the alloplastic material to put the implant at least 6 months after the graft, and preferable after 1 year with the alloplastic material, that the bone maturation would be final. Here again, we are using the condensers, of course, because the bone would not be dense. That's expected even without an X-ray. Remember always to have between 30 and 40 Newton. That's the implant in place. And we would talk right now about the enhancement and how we think minimally invasive in enhancements. Of course, every one of us have heard about the PRP, the PRGF, and PRF, platelet rich concentrates, the ultraviolet, and the atmospheric plasma. I'm not sure that all of us knows about the atmospheric plasma, but we will discuss. This is we get from the patient himself. We take blood, we do the separation using a centrifuge, and this is an invasive procedure. The cold atmospheric plasma, and that's a research that has been conducted in Ain Shams University in 2018. Dr. Ahmed Al-Qadi, Dr. Muhammad Al-Mufti. The cold atmospheric plasma has been used to increase the surface energy and change the implant surface from hydrophobic to hydrophilic, that it would have the cells, the blood moves on the surface. As you can see, the beginning. Group 2 with the platelets rich growth factors. When you put it, the implant surface, it does not, the implant surface is hydrophobic. It does not go smoothly on the surface. The plasma and the PRGF, when you do plasma treatment, here you can see how it is, and the surface suitability. And here is after the cold atmospheric plasma. It increases or it changes the surface from hydrophobic to hydrophilic. And this is how we apply with the external device. And it changes the surface into hydrophilic surface. Group 4, of course, was the control without any treatment or without platelets rich fibrin, and cases was completed. Here is what's important for us. This is the graph that shows that the cold atmospheric plasma, or the plasma itself, had almost the same results as the plasma with platelets rich fibrin, and it was better than the platelets rich growth factors. So here we can say that minimally invasive, when we go with external device like the cold atmospheric plasma, we would have better results without increasing the patient morbidity or taking blood from the patient or taking plasma from the patient. The photobiomodulation using lasers, you have to rethink possible. The biomodulation, which is something that is going with the most recent advances, that it increases the osteointegration and it increases the healing capacity of the part that we are applying the laser on. And I advise everybody to search for the photobiomodulation in implant surgery. This is also minimally invasive because when we are using the photobiomodulation, we might not need to use anti-inflammatory because it reduces the anti-inflammatory response, as we was talking in the beginning of the lecture, that non-steroidal anti-inflammatory impairs the osteointegration. So you can use the laser to reduce the inflammatory response, reduce the possibility of infection, and improve the osteointegration. That's a case where there was total destruction of the teeth, all the teeth. We had to extract all of them. It was subgingival, and the patient, we did it in on EA due to that the patient was not able to sit on the chair, on the dental chair, like the third patient in the beginning of the video that we showed. She had a trauma before, and that's why her teeth reached that condition. Extracted all the teeth, and she went out of the surgical room like this. The upper was fixed. It was immediate implantation and an immediate loading, and the lower was removable. So when we were applying laser, we was able to apply laser on the lower jaw, and we have not been able to apply the laser on the upper jaw. Here we can see the healing, or the difference in healing process. Here you can see this is after 15 days. Just 15 days from the surgery, and here we can see the mandible, and we can see the maxilla, the difference in healing between both. That's another surgery, maybe one, late implantation. Again, we are using the condenser because it was D3. Placing the implant. Adjusting the torque between 30 and 40 Newton. Inputting the temporary restoration. Now we are presenting the MIMI 2, which is the ridge splitting in the mandible, where there is no enough horizontal dimension. We are using the high speed just to cut into the cortical plate on the knife edge. We're just cutting a horizontal cut on the knife edge ridge, and we will start to use the condensers and the separator. Of course, this is 2.3, and let us talk about this ridge splitting, the MIMI 2, this ridge splitting. You cannot do the ridge splitting for less than 3 millimeter. It is not recommended to do it, or to put the implant at the same surgery. It should be in sequential. Between 3 and 4, you can start with the drills, because you will use the 2.3 and the 2.8, and then you'll start to do the separation, where you already marked the part of where you are going to place the implant. Then and of course here we are using the drills as well, because this bone was D1, and we don't want any pressure on the bone. Yes, we are doing the pressure while we are doing the splitting or the widening of the ridge, but this is a temporary pressure. It's not a permanent pressure. What's important is that you do not put the implant under pressure. The implant should be between 30 and 40 Newton to avoid any bone resorption. And that's on the left side as well. Of course, the thing that was most common complication in doing the ridge splitting while doing the flap is that you would have a crack or a fracture on the thin buccal plate. But even if you have a crack or even if you have a fracture, all what you will have to do is to put some stitches in, because the periosteum is intact and the bone would heal. So, in ridge splitting, we prefer to do this. We will use the drills if we have dense bone like D1. We will use only the condenser if we have D4, D3, or D2. And we place the implant without any pressure. If we have less than 3 milliliter ridge width, we do it on 2 surgeries, not in 1 surgery. From 3 to 5, of course, we will, or from 3 to 6, we will do this. Sometimes I prefer in D1 to do some closure and to remove the shuttle, especially in the mandible, because the tongue movement might cause extra pressure and it might loosen the implants. Here we can see that we have done the cortical splitting or the ridge widening without any flap. It's just the horizontal cut that goes to cut the cortical plate on the knife edge. Thank you so much for your listening. I hope it was a good lecture for everyone. Thank you very much.
Live to Give ISOD International Scientific Organization of Dentistry. كنا معكم ول5 أعوام سابقة ساعدنا فيها آلاف الطلبة والخريجين من كلية طب الفم والأسنان في كل مكان عن طريق التجميعات العلمية. Live to Give ISOD International Scientific Organization of Dentistry، أول منصة علمية متكاملة لكل طلاب وخريجي طب الفم والأسنان من كل مكان في مصر والوطن العربي. فاحنا بنقدم محتوى علمي وعملي ضخم ومتميز لأساتذة طب الفم والأسنان في مصر والوطن العربي، وده بيكون من خلال أكبر المؤتمرات العلمية أونلاين لأكثر من 18 دولة عربية. وكل ده بيكون على صفحتنا على الفيسبوك Live to Give. وكمان بنقدم أكبر داتا علمية مجمعة من كل الجامعات المصرية والكورسات المتميزة وكل اللي بيحتاجه أي طبيب أسنان عشان يطور مهاراته. وهتقدر توصل لكل ده عن طريق البوت الرسمي على التليجرام. وها نحن نعود إليكم من جديد في النسخة 5 من مؤتمرنا Empower Your Knowledge, a free online dental conference لكل أطباء الأسنان وطلبة الجامعات في مصر والعالم. نقدم لكم أكثر من 30 محاضرة متميزة في جميع مجالات طب الفم والأسنان. Case discussion, live demo and clinical cases. بدايتنا في 25 من أغسطس إلى 1 من سبتمبر، وستكون هناك هدايا وسحوبات يومية. Powered by ISOD. Live to Give. خير الناس أنفعهم للناس.